Hello, thank you so much for taking the time to watch this video. My name is Dr. Jenna Quinn. Many people do make the joke, Dr. Pre-Medicine Woman. I'm first and foremost a mom of 3 little girls, 6, 3, and 1. After 2 IVF babies, we found out 4 days after buying my LLC for Perfecting Peds that I was pregnant. So it has been an interesting, wild, amazing journey, just as life always is. So that is, and also I'm a wife, drive my husband crazy. So a little bit about my professional life is I'm a pediatric pharmacist. So ideally, well, all pharmacists have 6 to 8 years of education under their belt, and we get our doctorate in pharmacy. With that, we can actually niche down to certain different fields. So pediatric pharmacists have an additional 1 to 2 years of training. We also have board certifications that we get, and then everyone on our team, with the exception of one so far, has about 5+ years experience in the hospital setting, where I personally worked for 11 years in local hospitals, pediatric hospitals in PA and New Jersey. So we're out of New Jersey. And with that, we really, in the past 15 years, have really established our role, our unique role in 2 various settings, the hospital setting and academia. And so, like I said, our training is very unique. Children have very unique needs when it comes to medication management. So because of that, we all have very extensive training and education specific to pediatrics. They are completely different beasts as compared to any other patient population. We also all service maternal health patients because by nature of our training, almost all of us have NICU experience, and with that comes maternal health. So we always joke that we take care of the 2 patients that nobody wants to touch, a pregnant or postpartum woman and any child under the age of 21. But with that, we have, again, very unique knowledge because everything's weight-based, and there's a lot of different metabolism, genetic factors, age plays into it, maturity of their organs. So there's a lot that goes into medication management. And what I realized throughout my 11 years of being in a hospital setting is that we're a rarity. So to date, I think there's 1,200 of us that are board certified. And to date, we as pediatric pharmacists, we are only in hospitals. Some of us are in academia with an affiliated hospital. And then you have maybe a handful that I could find, maybe 5 to 10 pharmacists that are like one-offs being provided funding from either hospital or academia setting in an AmCare space. So we have not been utilized to date in anywhere, like I said, except with very few exceptions outside of the hospital setting. And within the hospital, we have very well proven our utility. And if you know anybody that knows a pediatric pharmacist, I know personally I would get 10 to 20 questions at least every couple of days from local parents or providers who worked with me who then went somewhere that didn't have a pediatric pharmacist. So long story short, we have very unique training and knowledge, and what I realized through our rarity is that we are only utilized in hospital, and we need to be spread out thinner because of our expertise. So when I was looking to be transparent, I was looking to get out of the hospital just because it weighed on me. I loved the hospital that I worked at, but working with critically ill children, like at their sickest, after 11 years in a pediatric ICU, neonatal ICU and ER, it does really weigh on you. But I knew that if I left the hospital, I wanted to stay in the ambulatory care space because the kids and mamas have my heart, and I wanted to make sure I stayed servicing them. When I started looking for jobs, I was like, this is not a thing in the United States of America. There are no opportunities for us. And that really my wheels started turning. So I'm in New Jersey. I previously, alongside of my hospital pediatric experience, when my oldest, who's 6, was 1, I started doing sales on the side. So that turned me on to flexibility, entrepreneurism, mindset, you name it. Like I love having people coach me. So with that, I started going to the local facilities, long-term care facilities, behavioral health facilities, medical daycares, acute care rehab. I started going door to door essentially and asking like who right now as a pharmacist is looking at your meds. And the answer was nobody. Started looking at even asking retail spaces, hospice patients, home care, you name it. And so what I realized was that a lot of times the states, every state in the US mandates for a pharmacist to be doing a med check essentially, but really a lot of the facilities, whether they're behavioral health, acute care, medical daycares, they have these pharmacists that are from these big pharmacy, long-term care pharmacy pharmacists, and they go in and they just do compliance checks. So they go in and they just check the box. They make sure the meds aren't expired. They make sure that that the narcotics are being counted, but there's no clinical decision making. There's no clinical recommendations. And so what I was set and why I made Perfecting Peds is because these kids that are in the ambulatory care space, specifically medically complex kids, so how we term that is a child that's on 5 or more meds continuously for more than 30 days, or or 2 or more greater chronic disease conditions. So these kids, whether they're in, like I said, we serve 5 facilities in New Jersey. So we service currently long-term cares, acute cares, medical daycares, private care, private pay patients all around the states. And what we realized was that these kids to date had never had a true comprehensive med management service. And because of that, there was an insane amount of polypharmacy. These kids were getting overprescribed. A lot of their meds were going unmonitored for common adverse reactions, not because, not because of anybody on the team, wanting these things to happen, but it's because, again, our unique knowledge puts us at this level to really evaluate and do a deep dive into their medication regimen and make these sort of recommendations. So what we decided to do with these 5 facilities in New Jersey is enter what's called a collaborative practice agreement. Collaborative practice agreement is that similar to an NP or a PA, where we can meet with the providers. We go over, basically what we can and can't do. And then anything that provides their input, we obviously go back and forth, and then we can actually implement any of the recommendations that we discuss or that we had deemed via the pre-approved agreement to make. So what I did, and when I found this out, I actually did not know and was not aware that this is the first time it was happening in the United States. So to date, there is no other, there's these complex, these long-term care, all these facilities around the United States where they have geriatric, not pediatric trained pharmacists going in and just checking boxes. So what we offer is a completely different, unique service. And not only is it helping the patients, it's also helping the providers, the nurses on staff. And we do this all, again, through a collaborative practice agreement. Because this is the first time that this is happening in the United States, my team and I actually turned it into research. And what we found was from 1,300 interventions, we were able to include 244 by that criteria. We found a hard cost savings because of how much they had polypharmacy on their chart of roughly $500 $500,000 over a year. And then we did our soft cost analysis, or I should say cost avoidance. And that was, again, close to $500,000 in 9 months. And then we were able to prevent 28 hospital admissions or readmissions from just adverse reactions being avoided, bunch of ambulatory care visits, and we were able to peel back the meds from an average of 23 to 20 on each kid's chart. And we obviously did monitor them to make sure that taking off a med, they were not being harmed, and we were monitoring them accordingly. There were situations where, of course, they needed a medication added. But with this data, because we were the first in the United States to enter these collaborative practice agreements in long-term care facilities, we showed our worth. The physicians were very, very excited to have us there. They were very appreciative. They wrote great reviews. And so from this and from having those numbers, we want to now scale into all the long-term care facilities we can, using just pediatric trained pharmacists to provide these remote comprehensive med management services. We also offer education to caregivers if they're involved, which is more in like the medical day settings. We also have compliance software that we offer them that helps them track when to give their kids meds, when to draw it up, how much to draw it up, if it's a liquid, if it's not, and what the syringe actually looks like. It gives them a nice video, or if it's a pill, it shows them an image, tells them some adverse drug reactions that can be expected, and then also when to contact us. We also do pharmacogenomics, which is we take a swab of the patient's mouth. Again, this is the first time this is happening in the pediatric population. We take a swab of their mouth. This is a covered service by Medicaid, and we send it off. What that tells us is how this patient uniquely metabolizes individual medications. From there, we can make a very unique plan for the patient or the child, just using their genes, knowing that certain medications they may react poorly to, others will work better for their DNA, and others we can anticipate that if we do it, may have to do it at a reduced dose. Some medications we can tell from their genes that they're an absolute no-go, that they would have severe adverse reactions if they started. So really, we're taking, the first time ever in the United States, this really innovative approach to pediatric patient care and maternal health in the outpatient setting. From this, of course, you know, entrepreneurism gets your wheels spinning. I mean, there's just such a need to service these kiddos. So, of course, I want to start and continue to service the patients who need us the most, which are these medically complex kids in these various facilities in the U.S. But I really also, in my dream of dreams, which is Lion coming to you, I want to also create an app. With this app, we'll have various functions. And so without getting too into the nitty gritty because of the NDA involvement, and I do have, it is under work. I'm working with a university. But with this, what we're going to do is basically, regardless of where you are, if you're a rural hospital in East Jabumble, or you're a mom in the middle of the night who's just trying to figure out Benadryl and they have the worst dosing on the bottles for pediatric doses, or you have, you know, a behavioral health kit and you really want somebody, that's a huge area I'm identifying a need for that a pharmacist can drive, is those behavioral health children, ADHD, anxiety, depression. And so with that, the app, I want to be a one place where you can come irregardless. And I want to, you know, sell it to hospitals for transitions of care. I want to go to pediatricians and say, here, use this, you know, you can have us, you know, basically call the pharmacist, you know, pitch it to OBs, because we are the experts in what's compatible with breastfeeding and pregnancy. And so my ask to you is obviously to help fund the app. And then I do, in my dream of dreams, want to buy a more robust EHR. The EHR we have, we're getting by, but I would love to buy something comparable to Epic so that we have the unique tools and constant innovation that I love from Epic. But again, we've proven the need. We've proven our clinical utility. We know that these kids need us. There's knowledge that we have that other team members don't, and we want to align ourselves with NPs and PAs, not diagnosing, of course, but just really helping drive safe and effective medication use for these vulnerable populations that need us. And again, it'd be working with me to emulate the first to date experience of having that pediatric pharmacist at your fingertips, and so many people in the area have used me, and even on Instagram, random people have used me as their on-call pharmacist, and then have us do more proactive drug reviews. So really, if the patient's like going 6 months in between visits, we have like a visit with them before the doctors, and then 3 months in, and really being partners with physicians. Full transparency, I do have a proposal out to a health insurance company. So again, I really, a lot of big contracts are coming. And with that, obviously, I'm going to need more pharmacists. So between my vision of the app, needing more up-to-date software, and then also needing to staff for these pharmacists, yes, I'll get money with the contracts, but you do a lot of work up front and then the money comes. And especially with these complex kids and moms, we end up doing a lot more than our contracts are giving us. So again, I don't want to cut into the patient quality of care, because as I've, because that defeats the whole point of perfecting Peds. So, but because we have to do a lot of upfront work, and then of course the contracts, the pay is delayed, again, that's another thing I would be using the investment for. Thank you for for bearing with me with my long-winded explanation. But I mean, the future of healthcare is here, having a clinical pharmacist on your team regardless of age, but really how I envision it is, if you're pediatric or a maternal health patient, you have your primary care doc, your OB, your whole set of physicians, and providers, but a pharmacist isn't on the team to date, and they really should be. Our clinical knowledge, like I said, is so unique, and we're in the best position with that knowledge to educate for the patient, to make sure that they stay safe, to make sure that we're monitoring them appropriately, to answer, their one-off questions like, hey, my neighbor, I started Prozac. Am I supposed to be nauseous? Is this normal? Like, yes, it is. So really be available to the patient to answer those questions. But again, if you're partnering with me, really, we have 7 contracted pharmacists right now, 2 physicians, an administrative assistant, and an awesome head of research. She is a pharmacist now, going back for her MD. She's crazy. But we have a robust team now. I would like to start staffing a lot of them from contractors to full-time, just so I can give you some extra insight on, where I envision the finances going, give you an insight on that there is a need, and we found it. And by partnering with us, you would help take care of the most vulnerable population. So thank you so much for taking a listen, and I hope to be meeting with some of you soon.